Good evening, students. Last week we were discussing neuroelectrophysiology introduction. This week we will touch upon upper and lower limb nerve conduction studies, and in that we'll concentrate on motor sensory nerves in upper limb and lower limb, and we deal with them separately. And also we'll consider some nuances of interpretation of the results of nerve conduction studies. And next week and subsequent classes will take up EMG separately, because there's so much to learn here. And after the EMG, then we'll go on to the individual diseases. So that's maybe about 1 or 2 months. We'll have about 8-10 classes only on electrophysiology, interpretation of right from carpal tunnel syndrome to radiculopathies and various other disorders we'll see. Okay, so with this introduction, let's start with today's class. And this is the premise with which we all know what is the EMG machine, and you have seen it. For those people who are they're just starting their career in neurology, this is going to be a tall order, because they are not exposed to these terminologies, and it will be slightly difficult to understand also. So, checklist prior to each study and before delivering a shock. The environment should be warm, quiet, and interference free. So the room should be properly earthed your equipment wherever it is kept. The earthing itself will cost about ₹1,00,000 properly if it is earthed. The pre-study checklist, where everybody should have a tape, a pen, a gel to apply the electrodes, check temperature. And where before you apply the shock at the patient, you verify the ground is attached to him and the active and reference electrodes are in place, and that check that the stimulation sites where you want it to stimulate are marked properly with an ink. And at the amplifier, verify again the ground, active and reference electrodes are in place and they are plugged into the correct channel. Make sure also that amplifier is on. At the screen, check the stimulation intensity. Check the side indicated on the screen matches that of the patient whom you are examining. At the stimulator level, adjust stimulation intensity, start low and then go up slowly till you get a waveform. You also should check the cathode and anode position, because in some studies they are reversed. In some studies they are straight wave. Cathode in the distal and anode in the proximal way. Start with a low intensity stimulation in the form of a shock, and this should be increased slowly by about 5 to 10 milliamperes for each subsequent shock. until a waveform is visible. You should manipulate the cathode of stimulator sideways on the nerve to get the largest possible amplitude. You have to continue increasing the intensity of the shock which you are giving, and then when you get a waveform, you have to increase the intensity by another 20%. That is called the supramaximal stimulation. So until the amplitude stops increasing, the waveform, the amplitude it will stop increasing. Then to add another 20% more intensity and shock. That's called supramaximal stimulation. So every test should undergo supramaximal stimulation. And before we conclude, we go on to the next now. So that these are the some of the important things which we do before the start of the test. And my sincere advice to all the students is that you should do neuroconductions yourself. You should know where the electrodes are attached for say median nerve, and they're attached for ulnar nerve and radial nerve, and posterior tibial nerve and fibular nerve, and where the stimulator is kept, where the reference electrode is kept, so these are things which you should know and you should do. And ideally, all the students should attempt to do neuroconduction studies. Basically, it is left to the technicians to do, but they are good teachers. Unless you do yourself, you will not be familiar with the interpretation of the various graphs you're going to see. Before doing any neuroconduction study, optimize results by reducing distractions and electronic interferences. We should clean the skin and ensure proper skin temperature. Just enough conducting gel, not too much, not too little. Be sure that electrodes are strictly attached. So the upper limb motor nerve studies will start. We'll start with the most important. These are the muscles, median muscles of the hand. Remember, loaf muscles, that is two lateral lumbricals, opponent's pollicis, abductor pollicis brevis, and flexor pollicis brevis. And usually an abductor pollicis brevis muscle is identified for the testing. Now, ulnar hypothenar opponents, flexor and abductor digiti minimi. And thenar is, of course, adductor pollicis, flexor pollicis brevis, two intraossei, and the lumbrical, all the intraossei, and the two medial lumbricals are ulnar purviewer. So these are the muscles. So in the upper limb, it's a brief review of what we do routinely. The median now, let's see. So last time we know that there are two electrodes, and the potential difference between those two electrodes is translated into waveform. Active electrode is placed over the center of the abductor pollicis brevis, and the reference electrode is over the metacarpophalangeal joint distally. The distal site of stimulation is the wrist between flexor carpi radialis and palmaris longus tendon, 8 centimeters proximal to E1 electrode. There is another proximal site which is medial to the biceps tendon in the antecubital fossa. And one more optional site is mid palm, allowing evaluation of signal amplitude proximal and distal to the carpal tunnel. The onset is given as upper limit of normal, amplitude as lower limit of normal. That onset means distal latency. So when we have to interpret, we have to keep that in mind. So this is how it is done, and you can see it's in the wrist. This is abductor pollicis brevis. It is this is the electrode that is placed, and this is, of course, the distal electrode which is placed, and the optional is mid palm, and across the wrist there is a carpal tunnel syndrome, and so you can identify the forearm pathology and pronator teres syndromes. As you see, E1 is the abductor pollicis brevis. E2 is the first metacarpophalangeal joint, and you can see the NCV or the right median nerve, which has that. We'll again discuss these analysis, MUP, CMAP analysis later. Ulnar nerve should be tested with the shoulder abducted 90 degrees and the elbow flexed to 90 degrees. The active electrode is placed over the center of the abductor digiti minimi ADM, and the reference electrode over the fifth metacarpophalangeal joint. There are two sites of stimulation. The distal site is adjacent to the flexor carpi ulnaris tendon, which is approximately 8 centimeters proximal to E1 electrode. There are two proximal sites. One is a below elbow site, that is 3 to 4 centimeters distal to medial epicondyle. After exiting from the cubital tunnel, you are targeting the nerve. Above the elbow site, posterior to the biceps muscle, at approximately 10 centimeters proximal to the below elbow site. So these are the two proximal sites. And so you have to elicit both these two sites of the ulnar nerve. You can see the ulnar elicitation here. So there are two types of stimulation, antidromic and orthodromic. That will come to later on. You can see the abductor digiti minimi muscle is targeted here. And fifth metacarpophalangeal joint, you have seen another electrode. So the stimulation, medial wrist, which is adjacent to, you can see, adjacent to flexor carpi ulnaris tendon, which is almost 8 centimeters proximal to E1. And below the elbow, that is not shown in the picture, that we have already read, 3 to 4 centimeters distal to the medial epicondyle. And above, it's over the medial humerus between the biceps and triceps muscles, which approximately is 10 to 12 centimeters from the below elbow side. So the across wrist Guyan canal, below elbow to wrist, forearm pathology, all these things can be studied with this. And also cubital tunnel syndrome can be studied. You can see the C maps at the wrist, at the elbow, below elbow and above elbow. You can see the differences in the morphology. And we'll study more about the morphology later on. That brings us to the radial nerve. It has a diagnostic value when there is clinical weakness or suspicion of radial neuropathy or brachial plexopathy. What are the recording sites? The distal recording site is over the extensor indicis propria, EIP. So here the active electrode is placed over the EIP, that is extensor indicis, 4 centimeters, which is proximal to the ulnar styloid, and to ulnar direction of the midline. The reference electrode is placed over the ulnar styloid process. The forearm, 8 centimeters proximal to 8 E1 over the dorsal forearm, the first site. Between the biceps and the brachioradialis muscles is a second site. And 8 to 10 centimeters proximal to the lateral epicondyle between the biceps and triceps muscle is the third site. Above the spiral groove and proximal arm is the fourth site. So radial nerve can be stimulated from 4 sites, and these sites we use whenever. So now we have seen medial nerve, ulnar, which are commonly done. Radial nerve we rarely do, but when required, we can do that also. You can see the radial nerve stimulation, which is E1 is extensor indicis, which is on the ulnar side. Ulnar side, you can see this is that 4 centimeters proximal to the ulnar styloid process. And the second one is E2 is ulnar styloid, and this is ulnar styloid process. So this is E1, this is the E2, and you are stimulating. Okay. So these are the 4 sites which you have seen, and usually it is done in dorsal forearm pathologies and narrow injuries at the spiral groove. And we can see the C map for radial like this in the forearm, and it's in the elbow, and of course it's in the proximal regions. So these are the 3 upper limb nerves, motor nerves we have seen. Every lab should endeavor to have their own normal values based on their patient population. So you should do at least 10 to 15 nerves and take the average of them. Whatever I'm submitting here, if it is same or above, then you can follow this. Stimulating at the wrist and recording at the abductor pollicis brevis for median nerve, the distal latency is about 4.3 to 4.5 centimeters. The amplitude will be 3.2 to 4.1 millivolts. In last class, we have seen already these denominations. And what are the normal values of ulnar nerve, which is stimulated at the wrist and recording in abductor digiti minimi? About 3.7 centimeters is the distal latency. And here the amplitude is better, 6 to 7.9 millivolts. So beyond this or below this, if you get, then you may think that's abnormal. So that's the motor nerve conduction studies in upper limb. Upper limb sensory studies. So there are three. There are median, ulnar, and superficial radial nerves we have to study. Upper limb sensory studies indicated in detection and localization of peripheral neuropathies, entrapment neuropathies, and plexopathies. Antidromic stimulation. That is, antidromic stimulation means you are sending the impulse. Normally, the sensory information goes from distal to spinal cord. The antidromic means the opposite of that. You are giving a stimulus which is spreading from proximal to distal direction. And you have to master the dermatomes and distribution of peripheral nerves to understand this. So you have to know where your C6 is, C7 is, C8, where is T1, where is C5, and also the dorsal ulnar cutaneous, superficial radial nerve, ulnar digital branches, median digital branches. These peripheral nerve details are a must. So the sensory branches of median nerve or palmar branch before carpal tunnel syndrome, it supplies sensation to the palm of the hand, and it's not affected in CTS. So in CTS, the palm of hand sensation is preserved. The distal branches, which arise after the carpal tunnel, the palmar aspect and tips of the lateral 3.5 fingers. 3.5 fingers. And this is, so if you are asked what is the point for sensory testing of median nerve, you cannot safely say there's a tip of the forefinger. That's the area for dedicated to this. The palmar ulnar cutaneous branch or PUC is before Guyana canal, supplies sensation to the medial aspect of the palm. So if medial aspect of the palm is preserved, then the origin of that nerve is before that. So it's not affected in Guyana canal syndrome. This is a question in your final year paper on Guyana canal and its anatomy. Dorsal cutaneous, ulnar cutaneous, DUC is before Guyana canal, supplies sensation to the medial aspect of the medial dorsum of the hand, the posterior aspect of the medial 1.5 digits. After Guyana canal or digital branches arise, they supply sensation to the palmar aspect and tips of the lateral 3.5 fingers. So that's how the sensory branches are divided in the ulnar nerve. So we have seen the sensory branches, and there are some of the nerves which are important, which we have to see. That is the posterior from the radial nerve, posterior cutaneous nerve of the arm, which arises from the radial nerve in the axilla. It innervates a small area on the lateral aspect of the shoulder. The lower lateral cutaneous nerve of the arm arises from the lateral nerve in the upper arm above the spiral groove. It supplies the lateral arm. The posterior cutaneous nerve of the forearm arises from the radial nerve in the upper arm above the spiral groove and supplies the lateral arm. And superficial radial nerve arises from the proximal forearm and supplies the skin of the dorsum of the hand and lateral 3.5 fingers. This is a nerve which we are going to stimulate for radial nerve conduction studies. So you can see most of these nerves are arising above spiral groove, and that's a point which neuroanatomically are very important. So the sensory studies elicit what is called as sensory nerve action potential snap. Abnormal snaps are seen in medial or lateral cord pathologies, and you know the brachial plexus divided into roots, trunks, cards, and nerves, and so RTDC. So this CTS and frontal teres syndrome, lateral and medial cord pathologies, the sensory nerves are affected, the snap will be affected. In CTS, if one of the digits is more symptomatic, you should use that for the study. The most sensitive test is called Combined Sensory Index, CSI. When we talk of CTS, we'll learn more about the Combined Sensory Index. So median snap, you can see how it is done. The E1 proximal phalanx, E2 is the distal ones. This is 14 centimeters. So this is the stimulation. So this is antidromic stimulation. E1 is a ring electrode on the proximal phalanx. E2 is 3 to 4 centimeters distal to it, and 14 centimeters proximal to E1 between the tendons of the flexor carpi radialis and palmaris longus. You can stimulate, and 7 centimeters proximal to E1 along the course of the median nerve, mid palm you can see. So this is the thinner eminence, and these are the ring electrodes, and this is the stimulation site. You can see approximately 14 centimeters proximal to E1 between the tendons of the FCR and palmar is longest. You can stimulate, and here you can see the mid palm, which is done in carpal tunnel syndrome. Now, ulnar nerve snap, the sensory nerve action potential of ulnar nerve. So now you have seen the median snap, which is which we have to concentrate on CTS, the carpal tunnel syndrome. The ulnar nerve snap is abnormal in lower trunk or medial cord pathology or ulnar nerve neuropathy. All these are mediating C8T1. Mind you, lower trunk C is formed by C8T1 radicals. Roots, that is C8T1, trunk, lower trunk, and medial cord, and also then ulnar nerve. The volume conducted CMAP may obscure SNAP here, that is compound module action potential. So the confusion should not be there. CMAP is in nerve conduction studies, MUAP is in EMG, that is motor unit action potential. So this you people should understand this. This can be reduced by placing even electrode more distal on the finger, ask the subject to extend and abduct the fifth digit. So the stimulation above and below the stimulation performed in the workup for ulnar neuropathy at the elbow. The sensory study across the elbow is more sensitive than motor nerve study for detecting any focal slowing across the elbow. There is a temporal dispersion and phase cancellation. These are two terms which I'm going to discuss in the end. The amplitudes are not meaningful. The dorsal ulnar cutaneous nerve is useful in differentiating lesions to the Guyon's canal at the wrist from the more proximal lesions. And Guyon's canal syndrome is an exam question, so everybody should know about this. The upper limb sensory nerve conduction studies, you can see the E1 electrode, ring electrode, it's E1. 3 to 4 centimeters distal to it is E2, and you have to stimulate 14 centimeters proximal to E1 on the medial aspect of the wrist, adjacent to the flexor carpi ulnaris tendon, and you can stimulate this and elicit the graph. The dorsal ulnar cutaneous, you can dorsal hand, web space between the little and the ring finger you put, and 3 to 4 centimeters distal to E1 or the little finger, you see the E2 electrode. Slightly proximal and inferior to the ulnar styloid with the hand pronated 10 centimeters proximal to E1, you can stimulate the dorsal ulnar cutaneous now. Upper limb sensory studies, the radial snap, superficial radial snap may be abnormal due to upper or middle trunks and posterior cord pathology. You see the upper and middle trunks, and the C5, C6, and C7. These are involved in the formation of upper or middle trunks. C5, C6 join to form the superior trunk. C7 continues the middle trunk, and all the trunks are called divisions, the anterior and posterior divisions. All the posterior divisions join to form the posterior cord. And so in that pathology, in the radial neuropathy, if there is a pathology in the posterior cord, upper and middle trunks, and then we can use this superficial radial snap. We'll study more about this when we discuss plexus also. The superficial radial nerve can be palpated over the extensor pollicis longus tendon when the thumb is extended. So you identify extensor pollicis longus tendon, and when the thumb is extended, then you see utilizing a ring electrode of the thumb allows for the comparison to the median nerve to the thumb, which is used in the combined sensory index, which we are going to learn in subsequent classes. You can see the lead placement, E1 bar electrode on the first web space, E2 3 to 4 centimeters, that is distal to E1, you place, and over the distal mid radius 10 centimeters proximal to the E1 is a stimulation site. So again, I remind you, all the residents should attempt to do all the nerves at least twice. Whenever you have an electrophysiology posting, and in big institutes, at least 3 months is given. Whereas when we studied, and I still remember my gurus, Mr. Bist and Ram Singh, who taught us how to elicit all these. So please learn from the technicians, and they are the masters. But we were made to do my teacher was Dr. Manvir Bhatia, and he insisted that all the residents should do their nerve conduction themselves. So we used to do a lot of nerve conductions ourselves, and EMGs also. So median snap peak latency is about 3 to 3.6 milliseconds. Amplitude is 6 to 10 microvolts. Ulnar snap peak latency. Here it's not distal latency, it's peak latency. So the differences which we'll understand in the lateral part of our talk. So just remember that motor we have done distal latency, and in sensory nerve action potential we are looking at the peak latency, because we cannot differentiate where it is taking off from after stimulus. That's why from the initial onset spike to the peak we measure. Amplitude will be 6 to 10 microvolts, and ulnar snap also almost same, 6 to 17. And you saw that ulnar CMAP also is high in amplitude. The radial snap is again further high, 7 to 15. The latency is small, 2.9 to 3.1 milliseconds. So these are the normative values of upper limb. Then lower limb motor nerve conduction. So what are the nerves we study in the lower limb? These are the tibial nerve, fibular nerve. And so tibial and fibular nerve, that is the deep peroneal nerve, which we're going to learn. So lower limb motor nerves, the posterior tibial nerve, which is targeted in the lower limb conduction studies. So posterior tibial nerve or tibial, and common peroneal or fibular nerves as they are called. Here the anatomy you should know. The sciatic nerve is formed by the ventral rami of L4 through S3. L4 through S3. So, in popliteal fossa, it divides into tibial and fibular nerves. The tibial nerve innervates the muscles of the posterior leg and then divides into posterior and distal to medial malleolus into medial and lateral plantar nerves, which innervate the sole of the foot. The peroneal nerve leaves the popliteal fossa, courses towards the fibular head, and separates into deep and superficial fibular nerve or peroneal nerves, which innervate the muscles of the anterior and lateral leg. And this is commonly entrapped here at the fibular head region. Okay. So now electrophysiology of the tibial nerve. Tibial nerve innervates the muscles of the posterior leg and divides into posterior and distal to medial malleolus into the plantar nerves, medial and lateral plantar nerves, which innervate the sole of the foot. The medial plantar branch of the tibial nerve innervates abductor hallucis, and that's a muscle which we are going to test and will be abnormal with any injury of sciatic or tibial nerve. Increase the pressure and stimulus intensity is required when stimulating proximally the popliteal fossa to obtain a maximal CMAP amplitude. So the posterior tibial nerve, first the distal site is behind the medial malleolus, and the proximal site is in popliteal fossa. It's a bit difficult to elicit, especially in overweight individuals. You can see the medial foot, there's abductor pollicis brevis, just anterior and inferior to the navicular bone. E2 at the first interphalangeal joint, metatarsophalangeal joint, and that is this you can see the first one, which is metatarsal joint, and this is abductor pollicis brevis. And ground electrode is in the dorsum of the foot. 8 centimeters is medial malleolus, and proximal to E1, just posterior medial malleolus. And second one is mid popliteal fossa. So these are the lead placements and the stimulation sites for tibial nerve. The peroneal nerve electrophysiology studies, and the peroneal nerve innervates the extensor digitorum brevis, EDB. The CMAP may be abnormal with compression at the fibular head. And this is, if EDB is atrophied, then you can use tibialis anterior. So the two muscles which you can remember is extensor digitorum brevis, and if it's atrophied, then the tibialis anterior may be studied. The lead placements for this, the extensor digitorum brevis on the dorsum of the foot, which you usually see in all cases of myopathy, you look for EDB apatrophy, isn't it? So it's easy to identify, and you can put the E1 electrode there. The distal myotendinous junction or the fifth metatarsophalageal joint, you can put the E2 electrode, and ground electrode is on the dorsum of the foot. All three are there only. Where do you stimulate? 8 centimeters proximal to the E1, you can stimulate that. Lateral to the tibialis anterior tendon, somewhere here you can see. This is the area where you are going to stimulate this. And below fibular head, this is easy to stimulate. Posterior and inferior to the fibular head, the proximal side. And above the fibular head, lateral popliteal fossa, just medial to the biceps femoris tendon also, the S3 side. So which we rarely use. So but these S1 and S2 of fibula are very important. You can see the dermatomes. I said you should master all the dermatomes which are present, where C2 is, where C3 is, C4 is, C5, C6, C7, C8, T1. All the dermatomes you should have in mind. So lumbar segment. Nandu, I am in class Amatamatam. So the sciatic nerve, as you can see, is formed by L4 and L5 and S1, S2, S3. And you can see those sciatic nerves are coming out. And this is divided into these two nerves, that is the common peroneal or fibular nerve and the posterior tibial or tibial nerve, which will supply the muscles on the back of the thigh and leg, that is the adductors, biceps femoris, and the hamstrings of semimembranosus, semitendinosus, biceps femoris, long head, and all supplied by these nerves. And so there are some root collateral nerves which originate at the beginning. Those are superior gluteal muscle and maximus muscles, and superior gluteal and inferior gluteal nerves. That involvement of hip extension or abduction tells us that it's a problem at the root level. And distally, involvement of eversion of the foot will tell us which nerve is involved. So that much knowledge we should have. You see the tibialis posterior, flexor distorum longus, flexor hallucis longus. These are the muscles that are supplied by the tibial nerve. And in the foot, these are medial and lateral plantar nerves. Sometimes the tunnel syndromes, and which when they come across with pain in the leg, you have to think of these things. The deep peroneal nerve innervates the EDB that we said. We already said that. And you see the stimulation of that. The lower limb sensory nerves, the most important now that we do is sural nerve. Sural nerve stimulation is a bit difficult task. And over to the it is usually the electrode is placed below the malleolus and the distal this is orthotromic type, where sensory information is coming like this. This is the, if you go this way, this is orthotromic, but this is coming like this, and you are stimulating the soleus muscle region. So the peak latency less than 4.5 milliseconds, onset latency less than 3.6 centimeters. These are the normal values of the sural nerve, and sural nerve will be. And then the other nerve which we want to see is superficial peroneal nerve also, which is distributed like this. Also, so sensory nerves, the lower limb, most important we do is sural nerve only. Okay. And the superficial peroneal nerve, and that we don't do. Then the third nerve which we do is the saphenous nerve. This also you can see the saphenous nerve, which supplies the medial aspect of the leg, and it's mostly L4. So the saphenous nerve is stimulated on the medial side of the L4 dermatome usually, and it is stimulated in the mid part of the tibial bone and just above the medial malleolus. So one more sensory nerve is the lateral cutaneous nerve of femoral cutaneous nerve, which causes meralgia paresthetica, which is a pure sensory nerve formed from the ventral divisions of the L2-3 nerve roots. And this travels deep intra-abdominally or the lateral border of the psoas and medial to the anterior superior iliac spine. Through the inguinal ligament, it comes out, usually innervates lateral portion of the thigh, but in some may also innervate the parts of the anterior thigh. So people usually present with paresthesia numbness in the lateral aspect of the thigh. It's called meralgia paresthetica. You can see that these are the obturator nerves. This is the you can see, and mostly this is the area where you get involved, and this is the area of the involvement of lateral femoral cutaneous nerve of the thigh, and that's how it is stimulated on the lateral part. And this is this. So we don't usually do this test. So orthodromic and antidromic conduction studies can be studied. Nerve conduction studies typically involve mixed nerves, such that they include both sensory and motor nerve fibers under physiological nerve conduction. The motor nerve action potentials, they propagate from the anterior horn cell distally towards the neuromuscular junction. The sensory nerve action potentials propagate from the sensory nerve endings proximally towards the dorsal root ganglion. So orthodromic and antidromic conduction studies are used in our day-to-day electrophysiology lab. The propagation of an induced action potential during the nerve conduction studies travels in both directions, proximally and distally, when you stimulate the nerve. If you are doing an orthodromic study, the recording electrodes measure the action potential traveling in the physiological direction. In antidromic study, the recording electrodes measure the action potentials traveling opposite the physiological direction. So all the motor nerve conduction studies are orthodromic. That is normal physiological direction. The sensory nerve conduction studies can be either orthodromic or antidromic. It has got its own advantages, and antidromic conduction will give more amplitude than the orthodromic in nerve conduction studies or snaps. Conduction velocities and latencies, however, are equal in both the directions. As I said, antidromic snap amplitudes are larger than orthodromic snap amplitudes. This phenomenon is attributed to the more superficial course of the sensory nerves distally, such that the recording electrode is in close proximity to the signal that is generated. There is some other explanation for the reduced amplitude of the orthodromic sensory nerve conduction. The distal branches of the nerves are thinner and are less excitable. So it's preferable to do antidromic in sensory nerve action potentials. So motor nerve conduction studies are orthodromic studies which measure the compound motor action potential, or CMAP, in the physiological direction, such that the stimulation site is proximal and the recording electrode is placed distally over the muscle belly, as you have seen in the abductor pollicis brevis and abductor digiti minimi when we were testing the median and ulnar nerves. The sensory nerve conduction studies are performed antidromically or orthodromically, both ways. So during antidromic recordings, the nerve is stimulated proximally and the recording electrode is placed distally. So that is opposite to the normal physiological condition. During orthodromic recordings, the sensory nerve is stimulated distally and the recording electrode is placed proximally. That is a normal physiology. One of the most clinically relevant assessment that utilizes both orthodromic and antidromic sensory nerve conduction studies is combined sensory index, which I have already mentioned that it's applicable in carpal tunnel syndrome, and which compares the median and ulnar nerve latencies, in which antidromic study is recorded a fourth digit and stimulated over each nerve proximally. An orthodromic study is recorded over the proximal respective nerve and stimulated at the mid palm. So this we'll learn more when we study carpal tunnel syndrome in the coming classes. So you can see the ring electrodes that are applied to the nerve conduction studies. You see, sorry. And if you are these electrodes are here, okay, and you are stimulating, and this is the cathode and this is the anode. The cathode is distally, and these are the recording electrodes. So normally sensory information goes like this, and then that becomes order. But here it is antidromic because the nerve the action potential is traveling like this on the nerve. So electrode and stimulator placement you have seen. Median sensory nerve conduction studies, which you can see the mid palm which he is doing, and here also the electrode is placed here, and the stimulator here, the cathode is here. Cathode is the stimulator side. So this is normal physiological transmission. Okay, electrodes and stimulator placements you just observe here. So sensory nerve considerations. The higher amplitudes observed in antidromic studies are considered an advantage. So nevertheless, the potential disadvantage of antidromic is the proximal stimulation is usually performed over a mixed nerve where both sensory and motor fibers are stimulated. Sometimes the CMAP also joins the SNAP and it will lead to confusions. The motor stimulation may induce a CMAP recording. The CMAP may be confused for a SNAP. This phenomenon can be more problematic when the distal latency of the SNAP is prolonged. So there are ways to overcome this. Because motor nerves are not usually stimulated in orthotropic sensory nerve conduction studies, recordings of a CMAP is not a problem. So when you do antidromic, then that's a problem. But if you do orthodromic, that is not a problem. So you have to balance what you want. If you want more amplitude, you do antidromic. There are some anatomical variations such as digit or limb size, which can contribute to amplitude difference. The amplitudes of the median snap in both orthodromic and antidromic studies has been shown to be inversely proportional to the wrist thickness. Both medial and antidromic nerve conduction studies inversely proportional to the finger circumference. So usually, if you are able to elicit a good snap, that is sufficient. We don't give much importance to the amplitude or a peak latency. And usually students say such snap latency is prolonged, but they are looking at the distal, they are not looking at the peak latency. And that is not very important. If you are able to get a good morphology of sensory nerve action potential, that is good enough for us to say that it's okay. What I was telling is we're going to talk about temporal dispersion and phase cancellation. Phase cancellation, temporal dispersion are the vital concepts to understand in order to accurately interpret variations in recorded CMAPs, sensory and snaps also. These are seen with distal and proximal stimulation. This becomes important in determining physiological from pathological conditions. Although the concepts are intrinsically linked and represent the same underlying electrophysiological technique, the best way to begin understanding them is by first separating them and see what are these. Basic concepts. Evoke potentials, which you are stimulating and evoking a potential. They are recorded in standard nerve conduction studies are a response of summation of electrical fields produced by depolarization along the nerve and muscle fibers of varying sizes. And some are fast conducting fibers, some are slow conducting muscle fibers. This is a mixed bag. The muscle fiber is the source of CMAP in motor conductions. The nerve axon is the source of SNAP. So large fibers depolarize more quickly than the small fibers. So there are some large conducting fibers and small fibers, as you know that the large fibers are important for the proprioceptive function. During a motor and sensory nerve conduction study, stimulating a nerve at both proximal and distal sites while recording from a single location, that is a recording electrode side is single, and it produces waveforms with slight differences in morphology. So for median nerve, first you distally stimulate, then you proximally stimulate both places. The potential closest to the recording electrode, that is distal stimulation site, will be larger in amplitude and shorter in duration. The potential farthest from the recording electrode, that is proximal stimulation site, will be smaller in amplitude and longer in duration. This is a normal phenomenon known as temporal dispersion, which occurs because there will be a difference in the conduction speeds of different nerve fibers. The temporal dispersion is the increase in the difference between the conduction times along the different axons within a nerve. There are some small, some fast conducting fibers, slow fibers. With increase in the distance, there is a large difference in the times of arrival between the fastest and slowest conduction fibers. So that gives us a problem, and that's the dispersion mechanism. Next. So one thing we calculate is area under the curve. The concept just is trying to understand area under the curve is a negative peak amplitude height, the height of the CMAP, plus negative peak duration, that's the length of a potential. This equals the summation of all the potentials or axons for a given compound potential. So you have to multiply the amplitude into the duration. If potentials arrive at the recording electrode, which is placed on the abductor pulsus brevis, at the same time, the greater the summation will be, and therefore the greater the amplitude. If potentials arrive separately, the greater the duration. So assuming a constant AUC, that area under curve, the number of axons stimulated with each recording yields an inverse ratio between the duration and amplitude. So area under curve is equal to amplitude into duration. In other words, if duration increases, amplitude decreases proportionately and vice versa. So this is a concept which we'll see further when we do the individual diseases. So this is the temporal dispersion and phase cancellation we'll see next. Summated overall potential seen during a nerve conduction study. The sum of upward negative potentials, the sum of downward positive potentials. This is the summated overall potential. So the distance between the two impulses traveling at different speeds will be larger with increased time. So this can be explained with the example of a runners running 100-yard dash or marathon compared to those in a marathon. I'll show you next slide. In both these scenarios, the area under curve is preserved. The total number of axons arriving at the recording side electrode is the same, but some are reaching fast, some are reaching slow. Although present in both snaps and CMAPs, the decrease in amplitude and increase in duration seen with proximal compared to distal stimulation most evident usually in the sensory conductions. That's why I keep saying that there is not much of importance for snap amplitudes and durations. If you are able to get a good snap, that's more than enough. That's really wonderful. But the morphology of snap should be very good because often it gets mixed with the compound muscle CMAPs. So that's why we have to be very careful in isolating this. And why this occurs is there's a combination of temporal dispersion as well as the principle known as phase cancellation. These two will make the amplitude and the duration of snaps very unreliable. You can see runners run at different speeds in 100-yard dash. With short distances, all arrive at the finish line around the same time, minimal separation. Each nerve fiber within the nerve conducts at a slightly different rate, but the impulses, they arrive at similar times, resulting in a large amplitude. So waveform of compound muscle action potential, you can see this is less dispersed and it is there. Whereas in a marathon runners run at different speeds. The large distances allow the fastest runners to leave behind the slowest runners. So there will be increasing separation. Similar thing happens in the nerve fibers. Each nerve fiber within the nerve conducts at a slightly different rate. There is a greater separation in the times when the impulses arrive, resulting in longer duration. Here, the amplitude is lower as compared to this. This is lower, but duration is increased. So AUC remains the same as in the first example. Area under curve is same, duration is increased. So again, we'll concentrate a bit on the phase cancellation part of it. A phase cancellation is a cancellation of a part of an evoked potential produced by the overlap of positive and negative components, and how it happens. All our action potentials, when you stimulate, they have both negative upward deflections and positive downward deflections. If an individual potential arrives at the same time in synchrony, so that all the upward deflections line up, all the downward deflections line up, the result would be a large negative upward deflection followed by a large positive downward deflection. With longer distances, when there is more time for separation, the potentials would not line up, but rather spread apart from each other and increase the duration. In this case, there is asynchronous. There is asynchrony of the axon potentials occur. So negative detection of one potential now arrives at the same time as the positive deflection of another potential. The upward and downward phases tend to negate each other. Because routine nerve conduction values only display the final summation, cancelled potentials appear as never having arrived at the recording electrode, even though they did. So you won't see any amplitude in these. That is a phase cancellation, which affects our technique at times. In this situation, despite increased duration, the amplitude is artificially decreased even further than would normally occur, resulting which is artificially low area under curve. It would be tempting to read the results as pathological because The amplitude drop was not accompanied by a proportional increase in duration, but the actual number of axons arriving at the recording electrode is preserved, and the loss of AUC is nothing more than a mathematical construct because of the reasons which I just explained. The different speeds with which action potentials reach the stimulation side, the electrode from the stimulation side. The slight latency differences in snaps can cause the negative peaks of slower fibers to coincide with the positive peaks of the faster fibers, and up to 50% reduction in snap area and amplitude. Less effect is noted in CMAPs as they are of longer duration, and less phase cancellation occurs as they tend to be superimposed more closely in phase over the same latency difference. That's why the snap amplitude is not at all important because of phase cancellation problems. You can see that runners A, B, and C, they challenge each other to a race with short distances all around the finish line around the same time. But each nerve fiber within the nerve conducts at a slightly different rate. The impulses arrive at similar times, resulting in larger amplitude. So they are less dispersed here. They are less dispersed, and the waveform of compound module action potential is shown here. And in marathon runners, runner A, you can see that runner A extends. So this is all to make you understand what is the type of nerve fibers and mixed nerve fibers have. The runner A extends his lead, and runner B slightly overtakes runner C. So that's how it happens. However, runner C is now completely masked from a sideline observed by the runner B, and runner B is overshadowing. So what happens? Each nerve fiber within the nerve conducts at slightly different rate. There is a greater asynchrony in the times when the impulses arrive, resulting in a mathematical cancellation of potentials that artificially decrease the amplitude. So whereas hidden behind the runners, this is the C. So this is the proximal or more dispersed. So this problem occurs more with sensory reaction potentials. That's why important is to elicit a good waveform. Don't bother about the difference in the amplitude, whether it's decreased or increased. How to account for temporal dispersion and phase cancellation? These normal physiological concepts are amplified under any pathological condition that prolongs the time needed to reach the recording electrode. One of the important thing is demyelinating neuropathy, where myelin is affected and saltatory conduction is slowed. So conduction block occurs when there is a demyelination across a nerve segment, which results in a greater than 50% loss of the area under curve of a CMAP when stimulating at a proximal compared to a distal site. That means if you are stimulating median nerve from the wrist, there will be a drop when you stimulate from the proximal elbow side. Demyelination and conductional block increase asynchrony between the potentials, allowing for the greater overlap between negative and positive phases, and more phase cancellations even in CMAPs. Therefore, when assessing neuropathies demonstrating abnormal temporal dispersion, phase cancellation, conductional block, they signify a demyelinating neuropathy. That's most important for our test studies. So one of the clinical polls is that demyelinating nerve lesion results in increased temporal dispersion, phase cancellation, conduction block. Prognosis is better because there is a limited, if any, axon loss in this conduction. But in axonal nerve lesions show reduction in the area under curve with the both distal as well as the proximal stimulation signifying loss of axons. Prognosis is worse due to loss of axons here. So let's look at some inherited demyelinating neuropathies, the Charcot-Marie Tooth type 1. Here there is uniform slowing of all the nerve fibers. Therefore, temporal dispersion, conductional block are not prominent features, but the distal latency is prolonged. Acute idiopathic demyelinating of neuropathy, AIDP classically demonstrate features of temporal dispersion and conduction block due to areas of focal demyelination along the various nerves, but in hereditary conditions, uniform pathology. When assessing a peripheral nerve injury or an entrapment, look for conduction block or significant temporal dispersion in a proximal compared to distal site, which can indicate a demyelinating lesion, which has a better prognosis than a lesion in which both these distal and proximal AUC is reduced, which would signify axonal loss. So understand that each motor nerve has to be stimulated twice in distal and proximal. So that's very, very important to understand that distal, why proximal. So analysis of results and what we have done so far, the nerve conduction studies. So nerve conduction and needle examination require knowledge of normal values and understanding of the significance of variations from the normal. These abnormalities can help diagnose a focal neuropathy, which distinguishes demyelinating neuropathy from an axonal neuropathy, and detect a myopathic process. So with peripheral neurology, either it is myopathic or neuropathic. There are only two things here. So where is the lesion? First thing is, and you can see that that's the peak latency which I was talking, which is the stimulation artifact is seen here. This is a stimulation artifact, and you can see the onset latency is from where it takes off, and that is CMAP. Usually we do this. For SNAP, we do a peak latency, that is the top one, because we are not very sure in SNAPs where this point is. Nerve conductions can be used to determine whether the lesion is distal, proximal, or segmental. Distal latency can be used to determine whether the lesion is distal. The latency measured is greater than the normative value for lab. It is considered prolonged. This is consistent with the slowing along the distal segments of the nerve. There are two types of distal latency that can be calculated, which I'll tell you. Distal on or onset latency, the time interval from the stimulation to the initial deflection of the waveform, which is from here to here is the distal latency. Motor nerve conduction studies typically use onset latency for assessment. That is, CMAPs have this. It is a measure of the fastest connecting motor fibers. Motor nerve conduction is not a pure test of time required for the motor nerve to travel, because it accounts for the time required for the electrical signal to travel from the stimulus site through the nerve segment, time required to cross the neuromuscular junction, and then time required for the muscle cell membranes to depolarize. So this is the whole thing. It's not a pure test of time required for the motor nerve to travel, but it also has neuromuscular junction and the muscle to activate. So that much time is there. Peak latency, the time interval from the stimulation, the peak of the waveform, and this is seen in SNAPs. Sensory nerve conduction studies typically use peak latency for assessment because the responses are smaller and it can be challenged to define a clear takeoff point for onset latency, for distal latency. So there is no involvement of neuromuscular junction or muscle depolarization. This latency is more of a pure test of time required for the sensory nerve to travel. Conduction velocity can be used to determine whether the lesion is distal, proximal, or segmental. Velocity is a representation of the speed of the fastest conducting fibers only. For motor nerve conduction studies, two stimulation sites for the same muscle must be used in order to account for the neuromuscular junction and muscle depolarization time, which is common for both the sites. The change in distance divided by change in time can then be calculated. That's what you use the tape for, no? Which we said you should have a tape with you. For sensory nerve conduction studies, this is more directly calculated by dividing the distance traveled by the onset latency. Peak latency cannot be used to calculate conduction velocity. So, but you can use here onset latency in the sensory snaps also. Normally, upper limbs greater than 50 milliseconds is the conduction velocity, lower limbs greater than 40 milliseconds, 40 meters per second. And in the upper limbs, it is 50 meters per second. The value for the velocity is less than the normal value, it is considered abnormal. Right? If it is more, it's not abnormal. If it is less, and represents an abnormality across the segment being tested. So, ulnar neuropathy, now let's take an example of that. Compression of the ulnar nerve in the cubital tunnel can be determined by comparing the conduction velocity of the ulnar nerve across the elbow to the distal conduction velocity in the forearm and the proximal conduction velocity in the upper arm. Slowing of more than 12 meters per second at the elbow in comparison with the wrist or upper arm is considered to be abnormal and suggests the compression. That's how you do the inching test and also conduction velocity test. So axonopathy or conduction block, how will you decide? The amplitude can be used to determine whether the axon loss, conduction block, or both are present along a nerve segment. So as you see, amplitude is defined as the maximum height of the response as measured from baseline to peak. You can see that baseline to peak or peak to trough if it is there. The normal amplitude values vary by lab and are equal to or greater than the value listed in a table of normal values. Exon loss, conduction block or both may cause amplitude less than the normative values. What is exon loss? The amplitude will be abnormal with stimulation both proximal and distal to the site of the injury. So amplitude loss will be there. It is secondary to Ehlerian degeneration and death of the entire axon distal to the site of the injury. So the amplitude will be reduced here. In conduction block, the amplitude will be decreased if stimulation occurs proximal to the injury and normal if stimulation occurs distal to the injury. This is secondary to a focal demyelination, which to block some of all conduction that pass to the point by saltatoric conduction. Proximal amplitude decrease of 20% or more, then the distal amplitude is consistent with the conduction block. In most motor nerves, it's not 20, maybe 50. Exon loss with conduction block. The amplitude with stimulation both proximal and distal to the injury will be decreased due to exon loss. But it's not so in cases of conduction block. The amplitudes with proximal stimulation will be decreased to a greater degree and by at least 20 to 50% due to concomitant conduction block. So when you are looking at the nerve conduction studies, your mind should be, am I dealing with normal study? Is it an axonal neuropathy or a demyelinating neuropathy? There is sensory neuropathy, a motor neuropathy, a mixed neuropathy. These all things will come into the mind when you are doing nerve conduction studies. So you have to spend some time in the lab, then only you can understand all this. So neuroconduction can help determine whether the lesion is neuropathic or myopathic. Neuropathic lesions can be located more proximally, such as radiculopathy, or more distally, such as plexopathy. In radiculopathy, the sensory nerve conduction studies is normal because it is distal now, no, post-ganglionic lesion, because the dorsal root ganglion is proximal to the injury, which results in Wallerian degeneration of both sensory and motor axons. In myopathic lesions, the sensory and motor nerve conduction studies are typically normal. EMG is needed for a diagnosis. However, in distal myopathies or severe myopathies in which both the proximal and distal muscles are affected, the motor nerve conduction may have low amplitudes. So I think most of the things we have covered. And what type of the primary sensory, primary motor? Then let's see. Some neuropathies can be defined as primarily motor or primarily sensory. Like Friedreich's ataxia, the nerve conduction findings are typically demonstrate decreased or absent sensory potentials and normal motor potential. This is primary sensory neuropathy. Multifocal motor neuropathy. Here the NCS, the nerve conduction studies findings typically demonstrate conduction block and motor conduction studies and normal sensory potentials. So you also can estimate how long has the lesion been present. After nerve injury, motor axons may remain excitable for up to 7 days. And sensory axons may be excitable up to 11 days. So with even severe proximal nerve injury, stimulation distal to the injury may result in normal or only mildly abnormal values during this time period. So it's not useful to do these studies in 7 days or 11 days. Stimulation proximal to the site of injury will result in absent responses in both motor and sensory studies, making it difficult to distinguish axonal loss versus conduction block. It is thus recommended to wait 10 to 14 days after the injury before performing nerve conduction studies, as the difference in the pathology becomes clearer after this time only. So what are the factors that limit the interpretation of the nerve conduction studies? Decrease in limb temperature could prolong the latency, increase in amplitude, and decrease in conduction velocity. There may measurement error of distance could limit the calculated conduction velocity. Anatomic anomalies may lead to unexpected sensory and motor nerve conduction findings, which we'll take up next class. So we'll do anatomic anomalies of the nerves along with EMG. Edema or subcutaneous tissue could impact the level of stimulation and leading to a falsely decreased amplitude. So there are some limitations. With this, we'll finish today's class. We have studied all the motor and sensory nerves, both upper and lower limbs, and we have also learned about temporal dispersion and phase cancellations. And we also learned that for the sensory nerve action potentials, the phase cancellation will make us unreliable about the amplitude assessments. With all these few words, I think we'll go on to the F wave. And the F wave, that we finish then we have two small things to do. That is F wave and H reflex. The F wave and H reflex are known as late responses. Late responses evaluate the entire nerve from the root to the neuromuscular junction. Routine nerve conduction studies only test the distal segments of the peripheral nerves, but F waves, they represent the antidromic motor responses obtained following electrical stimulation of a peripheral nerve. They are most useful when the distal segment is normal, like as in radiculopathy, and the proximal segment is abnormal. Measuring a longer segment allows detection of a proximal or diffuse problem, such as demyelinating process also. So F waves are prolonged in CAIDP. Sometimes assessment of distal nerve segment is required, that is in carpal tunnel syndrome. So most commonly, this is used in entrapment neuropathies and as well as AIDPs. F response anatomy is not an acute actual reflex. A reflex is defined as a response that goes through a sensory component. Here, the synapses in the central nervous system then travels back down the motor pathway. But it's not the case with F wave. With F waves, the pathway is from the motor fiber to cell body and back to the motor fiber. So the impulse is first propagates proximally, that is antidromically along the motor nerve to the cell body in the anterior horn. The F waves can be studied in all the motor nerves. As the impulse approaches cell body, the membrane at the most proximal part of the axon, where it meets the cell body, which is called axon hillock, that is the first part of the cell body to see the impulse, the first part to recover after the refractive period. Blocking of this antidromic potential usually occurs at the hillock. So the signal that travels around the rest of the cell and essentially circles back to axon hillock. The timing is such that a very small percentage of motor neurons get reactivated and send an impulse back down the motor pathway orthodromically, about 1 to 2%. So you see, to get this 1 to 2% bounce back, one needs to stimulate all of the motor fibers, requiring supramaximal stimulation. This is in contrast to the H reflex, which we're going to study, which requires submaximal stimulation. The response you get is actually very small, about 1 to 5% of their compound module action potentials. Because it was detected first in the foot, it's called F wave. The setup for F wave is very similar to that of a routine motor nerve conduction study. But there's one difference here. You have to flip the stimulator so the cathode is proximal, the anode is distal. This is to prevent theoretical anodal block. Stimulation intensity is gradually increased until the supramaximal stimulation intensity is obtained. Then a series of waveforms are recorded, usually at least 8 to 10. The modern electrodiagnostic software allows for averaging of all the F wave traces. Each of the F responses obtained represents different fibers, therefore will vary somewhat in latency, configuration, and amplitude. After performing all of the F waves, look for a normal pattern. Mark the minimal F wave latency. These are most commonly used. Presumably, the fastest recording represents the largest and fastest motor fibers. Check against normative value. Taller individuals will have longer latencies. Count the persistence. This is defined as the number of F waves obtained divided by the number of stimulations. Use of persistence is controversial. Fibular F waves are normally have low persistence. Measure the chronodispersion. This is defined as the difference between the fastest and slowest F waves obtained. There is some evidence of increased chronodispersion, lumbar canal, lumbar spinal stenosis after subjects walk or stand for 3 minutes and become symptomatic. The mean latency of 7 F wave latencies is seen. This reflects the average of the recorded F waves. Potentially the most accurate measurement of for clinical application is this. You can see you are stimulating here. This is a muscle. This is a neuromuscular junction. You are stimulating here. The muscle is going This is towards the proximal, and there is no synapse here. It goes to the cell, all around the cell it goes, and same fiber it comes back to this, and you get a okay, you get these are the F waves which you see on the graph. One condition for which F waves are useful is Guillain-Barré syndrome. It's a segmental demyelinating disorder that results in ascending weakness, starting with the distal muscles and propagating to the proximal muscles. Early in the course, the nerve roots are often preferentially affected. Therefore, the GBS, the only abnormality may be delayed F waves. This makes them a crucial part of the diagnosis. Limitations. F waves test the entire length of a peripheral nerve. An abnormal F wave does not indicate where along the pathway the pathology lies. It tests only the nerve roots that innervate the muscles tested. In the upper limb, F waves are most often performed with the median ulnar nerves, which are innervated with CA-T1. In the lower limb, they are usually performed with the fibular and tibial nerves, which are L5S1. So other nerve roots are not tested at all. C5, C6, C7 not tested. L2, 3, 4 is not tested. So F waves test only motor nerve fibers. The peroneal F waves may have absent, may be absent in normal subjects, may be absent in sleeping or sedentary patients, and in cases where distal motor unit amplitude is reduced. That means if you got a CMAP amplitude is reduced, then F wave may be absent. But the F wave to be absent or for the minimal latency to be delayed, all or most of the fibers have to be affected. So that brings the end to the F wave, and lastly we do a H reflex. The H reflex is a monosynaptic reflex, unlike the F wave that was first described by Hoffman in 1918, and it is used for only one thing: S1 radiculopathy, most common radiculopathy in the lower limbs. Most common use of H reflex is this one. It assesses the conduction properties of the S1 nerve root in the neural foramen to investigate the possibility of nerve root compromise, which would lead to an increase in latency or slowing. And we'll see what is an F wave and what is the H reflex. Cervical radiculopathy, brachial flexopathy. The H reflex can be tested in the flexor carpi radialis to assess the C6 and C7 nerve roots also. In the lower limbs, it is S1 nerve root. And polyneuropathy, GBS, tibial or sciatic neuropathy, lumbosacral flexopathy also may show abnormalities in H reflex. Orthotromic sensory afferent, 1A muscle spindle afferents carry the impulse to the spinal cord. A synapse in the spinal cord at the antihorn cell or interneuron, and orthotromic motor efferent, alpha motor neuron carrying the impulse to the muscle and completing the arc. The H reflex represents a delayed motor response, which is equal to ankle jerk. Unlike the F wave, which can be obtained with any peripheral motor nerve, H reflex is only routinely obtained at the soleus muscle. Here, the H reflex travels along the tibial nerve, assesses only the S1 fibers. It is electrical correlated with the gastrosoleus muscle stretch reflex, tested as the ecclesiastic called ankle jerk. It may also be performed with the flexor carpi radialis, but it's not commonly done in the upper limbs. So what is setup? E1 is over the soleus muscle, that is first electrode, measured halfway between the popliteal fossa and medial malleolus. E2 is over the posterior calcaneus. Ground is proximal to the active electrode. Stimulation in the popliteal fossa with the anodal distal to the cathode. Both the sensory 1A afferent and the alpha motor neuron efferent in the tibial nerve are stimulated simultaneously. 1 millisecond duration, long duration current, submaximal stimulus has to be applied. And successive stimulations are performed while gradually increasing the intensity. The goal is to find the stimulus intensity that will give the maximum H reflex amplitude and minimal latency. The cursor is then placed at the point that marks the minimal latency, and C will show that. The minimal H latency, the most commonly used measure, is usually compared side to side or can be compared to the normal population. The latency varies with leg length and age. Upper limit of normal latency is 30 to 38.2 milliseconds depending on the age and height. So there is less than 1.2 millisecond difference between side to side. So at low stimulation intensities, the 1A sensory afferents are preferentially stimulated and only an H reflex will be seen. As the simulation intensity gradually increases, the H reflex amplitude increases and the latency decreases, and I'll show that. You can see the strength. If strength is increasing, you can see the CMAP is this, and you almost the H reflex is gone. But in the low intensities, that is to 5.2 and 2, the H reflex is coming. As the intensity is increased further, the M wave begins to appear as and the amplitude of the H reflex decreases. This is the M wave, this is the H reflex. And at higher intensity, the H reflex disappears and the M wave predominates. Thank you very much for your attention. We have gone through a lot of things today. Still, we have to learn a lot. And let's see in the next class, we'll try and cover whole of EMG. And before we start our journey with various disorders, so any questions or any queries you want to ask, you can ask before we wind up. And you can always send me also an email. Any questions? You can put it in chat box if you want. So if you say that what we did was we have completely studied the upper and lower limb motor and sensory nerves, and we have analyzed the CMAP, compound muscle action potential, and sensory nerve action potential. We learned about temporal dispersion and phase cancellation. We know how to analyze what is axonopathy, what is demyelinating neuropathy, conduction block, and how it happens. And we also studied about the F wave and the H reflex. So, any questions? Are you all there or sleeping? At least put something in chat so that I get interested to teach. Is it very tough for you people to follow? When we go slow, unless you give me feedback, you will suffer. So let us learn together and give me suggestions how you want it, so that we can fine tune the subject also. Okay. Something. Let me see on there. Oh. There are many books to refer, and this is a mixture of many books. So this lecture will be there on the YouTube. So this is enough for you to begin. I'll suggest that book which we have as an DM student. I will bring it to. I'll show it next time. So, but there is this much is enough for the practical knowledge. Okay. Okay then. Good night, all of you, and we'll meet next Monday probably. If I, for any reason, I'm not able to take next Monday, I'll take the next Monday. Okay. Otherwise, we'll stick to the Monday schedule for neuroelectrophysiology for till we finish our target. Okay then, and thank you. Good night.